All right, I'm going to be punctual. We've got a lot to cover. So again, good evening and thank you for joining us tonight and welcome to our webinar. I am Wendy Golden. I am an endodontist and medical affairs for Sohn Endo. Tonight we plan to cover three objectives. We're going to understand the application of innovative irrigation technology. We're going to start to explore conservative canal preparation and what that looks like, and also analyze case studies with unique anatomical challenges. The webinar does include 1.5 CE units, so let's review how that's done. One, you must be registered for the event. Your attendance is going to be recorded via the Zoom. We want to make sure your full name is visible in your Zoom profile, and if it's not, you can message me in the chat with your name and we will make sure you get credit. We will send you a survey via email. Please complete that, get us back to us, and then we will send you your CE certificate. Any questions along the way, please reach out to myself or education@sonendo.com. Tonight is a fabulous turnout, and we want this to be an interactive session. Your questions are deeply encouraged throughout the presentation. Please put them in the chat box. After Scott has finished talking, we were going to go through the chat box, and then you're welcome to come off mute and camera and ask some live questions to him too. It is my pleasure to introduce you to Dr. Scott Hetz, a friend and colleague. Dr. Hetz is a 1997 graduate of the University of Pittsburgh. He served in the United States Air Force for 9 years, including an advanced education and general dentistry program. While on active duty, he also received his specialty in certificate in endodontics at USC and graduated in 2004. Dr. Hetz is a diplomate of the American Board of Endodontics and a member of the Endodontic College of Diplomates. He volunteers at the Walter Reed National Military Medical Center. Dr. Hetz maintains a full-time private practice as a partner with Advanced Endodontic Associates in Washington, D.C. So, Scott, the floor is yours.
Wendy, thank you very much. Let me move a couple things over here. Welcome, everybody. Thank you for the kind intro. The title says, complex anatomy, a strategic approach using cone beam and GenoWave. Let's see here. So we're going to start out with Dr. Nito Kubane. He's the president at High Point University. He's got a quote: "Creativity is about doing things differently, but innovation is about doing them better." There we go. Well, let me tell you, it's a real honor for me to have one of my mentors participating this evening. I want to thank Steve Buchanan for investing his time with me going back over 20 years ago at Southern Cal. And Steve, you taught me to embrace innovation, as well as you always taught me to be curious. You're a great example of how to approach endodontics with a sense of curiosity. So I appreciate you and everything that you've done for the specialty. Most of you who are in this call tonight have all three of these modalities available in your offices. In my humble opinion, this trifecta of GenoWave, cone beam, and BC sealers embody Nito Kubane's quote: "I use these tools to enhance predictable outcomes and improve the patient experience at my office every day." Some brief housekeeping. I am a KOL speaker for Sohn Endo, so I do receive an honorarium for speaking tonight. But I've also included my email for any continued exchange of ideas. On another note, I actually do know personally, I think about a third of you on this call tonight. So I really expect a lot of fun during the Q&A. And if we're not getting a lot of questions, it gives me an opportunity to call on people. I will highlight certain materials and instruments I use in my practice of endodontics. However, I am not receiving any discounts or materials at no cost. the impact of cone beam in endodontics has been scientifically quantified. Mo Fayad's group back in 2014 published in the JOE, and they had provided all the relevant diagnostic data to board certified endodontists and asked them the treatment plan based on 2D imaging alone. At a later date, the same specialists, the same cases, but adding cone beam, and they were asked to once again determine their approach to treatment. And the results don't really surprise me at all. Based on the information being from cone beam, they modified their treatment 62% of the time. And since adopting cone beam into my practice in 2010, that diagnostic data available by cone beam has made a significant impact on our, what I call, everyday treatment planning. So let's talk about that other number, 2014, okay? So what percentage of endos in North America had a unit, a cone beam unit in their office? And if you did, you have to go back and ask yourself, what was your utilization? How did you use the technology? What did you feel it was beneficial, or were you a little bit stingy with it? Did you use it every day? Because I think today's landscape looks a whole lot different. Also, now tonight, how about the utilization of GenaWave? All right. And I want you to take a moment to kind of think about your own practice and how you utilize that technology yourself. I believe most of the people on the call tonight do have GenaWave. So let's kick things off by comparing two cases. First is a routine case, just the calcified molar, and the second one on the right is a more complex retreatment. Because what I'm sharing with you is exactly what I'm doing in my office. This is a standard case. There's nothing crazy here. These are very calcified canals. Maxillary first molar. Got some apical pathology. So the result here is nothing very sexy. There's a little bifid at the MB apex. But what you notice here are just dentin conservation through minimal preps. Very small, skinny preps. This is kind of my classic standard GenaWave root canal. And now we've got a more complex retreatment situation. So I see a missed canal, there's lack of patency. So here's a quick peek through the surgical operating microscope. So there's a lot of coronal leakage. So we're going to start and tidy things up, locate the MB2, but check out the rubber dam isolation, because I am going to use GenaWave. So I'm already thinking about building a platform before I isolate. So that's a number 9 clamp. So I can control the soft tissue with some Oraseal, and it enables me to build a bulletproof platform because I'm going to use GenaWave on every single case. So this is an orifice barrier placed, case is packed. Here's the result. We take another look. So that little bifid at the palatal apex, using cone beam filters out root fractures, which is going to enhance our outcomes, our percentage of positive outcomes. But there's another bias, all right? What kind of lateral anatomies do I think are going to show up when I use enhanced irrigation? So I can really look at those areas of low density where they are on the root form and kind of predict, where am I going to pick up extra anatomy? And this is really the question I want to ask you tonight. So when do you determine that you're going to use GenaWave? So my content tonight is an interactive discussion, and differing opinions must respect the insights and the intelligence of the other party. So we don't all have to think the same way, but I just want to share with you a little bit of what I'm doing here in DC. Full disclosure, I take a cone beam on 100% of my patients. I also strive to use GenaWave on about 99% of my cases, because missed lateral anatomy in MB1, that case on the left that you see, is a much different story compared to missed anatomy in the palatal apex on the right. That's not exactly a surgical candidate in my practice. Maybe somebody else's, but not mine. Next case, we should always consider root fracture, but I think there's a lot of undiagnosed endoperio out there. So you see there's a missed canal, you have a furcal lesion, but there's an element of discovery. And sometimes you actually have to go all the way down through the case and obturate it, all right, to see those anatomic possibilities. You need to validate, but it's only going to happen at the end of the case. This is what I anticipated. So you can see here, little lateral canal coming off the untreated MB2. And picked up this little bifid. But this is why I'm using GenoWave, because a lot of this stuff I get to discover at the end of the case. So I'm not pre-selecting, a certain case, whether it's a GenoWave case or not a GenoWave case, if it's vital, if it's a retreatment, it's necrotic. And I want to definitely have a good discussion about that after I get through the content tonight. Here, this case was treated to an adequate standard of care. There's not patent on MB1, but the lamina dura is intact. Look at the anatomic position of the area low density. So when I retreat this, my goal is not patency for MB1, and nor do I want to continue that confluent MB2 to be patent. I'm looking to target. I want to get into that previously treated MB2 to get to the lateral canal I think that's there. Because in my practice, there's a very low probability of getting any files into that area. I'm really counting on the fluid dynamics of GenoWave. And there you go. There's that little guy right there. That's the whole case. I think we're doing a lot more surgery before. I've been using, this is my 8th year of using GenoWave, and sadly, I do a lot less surgery than I was before. So these retreatments are becoming far more successful. One of my best friends, Bill Nudera, had coined the phrase selective root retreatment. He's got a really nice paper in the JOE. I've taken that one step further with GenoWave, and I call them targeted retreatments because I'm really going for a certain anatomic space, and I just want to create a fluid pathway to get to that area to get to the result we want. And, who hasn't treated or retreated their own cases? So I want to kind of take a little bit of time on this one. This is a 2016 root canal. So you see the pre-op on the left, second molar, you can see the result on the right. This is my 2016, but the patient came back in 2023 with symptoms. So there's the pathology. We got a fused root situation, and the pathology is right in between the two of them. So we discussed all the treatment options to include intentional replant. And if she'd opted for extraction, you might as well let me do it. However, she elected to go with my primary recommendation of retreatment. But what's my modification going to be? What am I going to do differently that I didn't do the time before? Well, here you can see in the post-treatment, that anatomy, how am I targeting that? Well, I'm not really making an objective to be patent on the palatal or the MB. I'm just looking to remove that gutta percha, because this was really a surprise. I thought I would have a little lateral canal for one of these that would have led over there. This was a complete surprise, but the principle is the same, which is the lamina dura at the POE was intact. I'm looking to open up in advance of that and then really generate some hydraulics on the obturation to get that filled. And you can see how wide that isthmus is. It's just untreated isthmus. Like a lot of these failures in endodontics, it's a failure of irrigation or canal identification as opposed to anything else. And now we have the 2016 post-op on the left and the 2023 post-op on the right. Of course, we want to validate that with a cone beam follow-up. So now you can see with 75 microns that lamina dura is back intact. Symptoms resolve very quickly and directly after retreatment, but I ended up seeing her about a year later. And this here was a case, this is a case I treated yesterday in my office. So the patient doesn't have any symptoms. They want to redo the crown. So they took an image and there's this pathology. So they've got interradicular areolar density. So the cone beam confirms the lamina dura is intact at the POEs, but that areolar density is really associated with the mesiolingual canal. And there it is. That's my target. That's what I'm after. I'm after that little bit of isthmus space just off of mesiolingual. I do take an immediate, on cases like this, I do take an immediate post-treatment cone beam. Again, I want to validate where I've been. But can you believe that tiny little untreated lateral anatomy was to blame right there? But I think this is what makes it so fun, because the novelty is in the details. It's like a little game you got to figure out. I don't know if anyone here on this call attended Dr. Yamario's 2025 lecture at the AAE. And if you did not, it is now available, Endo on Demand. And you can find that at aae.org. David put out a very objective and convincing histologic data. And kind of the punchline is GenoWave is king at tissue dissolution in the arena of enhanced agar irrigation, period. Please check out his content. It's pretty good stuff. But moving on, again, this is nothing crazy. We see this in our practice every day. We have an untreated MB2, MB1's not patent. So it's, again, this is not crazy. These fused root situations offer their own special kind of challenges, specifically locating and navigating. But this is how this patient presented radiographically. Here's how she presented clinically. Definitely a lot of pain. So I'm probing, there's purulent exudate, open the tooth, and just taking out the core, this is what I had. So it's draining from the untreated MB2. But here's the rub. I couldn't really instrument MB2. In fact, that little arrow there designates the extent of mechanical instrumentation. I could not get beyond that point. I used every single trick in the book, and that's as far as I could get. So what's the next move? All right, well, it's draining. There's a pathway, so let's run GenoWave. So now we're looking back. You see the obturation, but how did I do the obturation? What's the next move? I modified the sealer delivery to get the job done. So I took one of the minimal waste tips and I cut that at a diagonal. And now going back, you have a lot of control here. That sharp little pointed tip will fit into the orifice of a minimally prepped canal that has no real orifice opening established. So you can tuck that in there, give it a little push, make it snug, and start to advance some sealer. Followed by some compaction of thermoplasticized gutta percha with a little push of sometimes just the Endo Explorer. I can't even give it a probe in there. Generates enough hydraulics to advance the obturation into the areas cleaned by GentleWave. And there's the immediate post-treatment. This is also a case that's relatively new. So this is a soft tissue check at 4 weeks. But when the soft tissue responds favorably, it's a really strong indicator that you're going to get some healing in the bone as well. So we talked about creativity, right? And I think we all have a tool, and I think it's a new way to connect with our patients. And the way I look at this, when I go in the office every day, I'm asking myself, how am I going to accommodate this technology? How am I going to accommodate the case so I can make sure that I have the option to use the technology? Because tucked away in that console are creative possibilities I think I've kind of dreamed of before. I'm going to start into a few resorption cases. And I'm going to tell you that, of course, when you look at I guess it's a training manual, this is off-label use of the technology. I mean, we're still the doctors. I've had a lot of experience with this. I personally feel very comfortable approaching these cases, but I think there's a lot of consideration, and I think that you really got to make this decision for yourself if you're going to move forward and treat resorption. So this tooth number 31, invasive cervical root resorption, and this is positioned, this defect is oriented lingually under the pulpal floor, which is also contiguous with the lingual furca. So the next image here is GentleWave has already been run, all right? And we're now looking through the surgical operating microscope into the distal canal and the pulpal floor. You can also see the topography of the resorptive lesion. This is immediately after GentleWave. So it's really, as we know, just a prophylactic root canal, an intentional root canal, just so we can get to the resorption. Here's another view into the mesial aspect. And on the right, I've kind of tipped the mirror a little bit just to capture a more direct image of the lingual. And I want to get some hemostasis because we got to obturate this. All right. So to get from here to the next slide where it's not bleeding, I'd obturate. I just do, obturate the canals first, just to the orifice level. And then to get this bleeding to stop, I use hypertonic saline that's chilled. I deliver that with a very open-ended MAC tip, MAC. It's really just a blunt force of freezing cold salt water right at that pulpal floor. You can't hurt anything with salt water. And it tidies it up almost immediately. So I'm not using hemostatic agents. That's how dry we get it. Now we're ready to obturate the resorptive lesion. Again, just another view of the pulpal floor. So the first thing I do is just apply a generous layer of endosequence BC sealer. I only use endosequence by name, and I air thin that. Then reapply a sealer again, just to ensure coverage. On top of that, we're going to place some BC putty. Tap that into place, but we really haven't generated any hydraulics. We got to really start to move that sealer and then impregnate all of those irregular areas. It's almost like sea coral. You want to impregnate all those areas with the putty. So what I do is I fill the chamber with thermoplasticized gutta percha, then using a maximum amount of plugging pressure to create hydraulics, give that a push with a larger instrument. Pack that into place, and I'm really forcing the sealer down through all the areas where GenaWave has dissolved the offending tissue. And simply pop that gutta percha out. So we're really taking advantage of that nanoparticle technology of BC Sealer, as well as the outstanding flow properties, to get into the areas that we want to get to. And here's a comparative coronal view. You can see sealer penetration to every nook and cranny. Everywhere where GenaWave was able to dissolve tissue, we've replaced it with sealer. And then descending axial views through the pulpal floor also demonstrate the same. And an inverse contrast with 2D imaging also provides, another view here. The vertical bite wing helps demonstrate what I call kind of a subterranean infiltration of sealer that's positioned under the pulpal floor, which we had no access. So you can't really take a round burr and start to carve this out. You might as well just extract the tooth. So it's kind of a creative solution to help this man save his tooth. And here's 16 months later. I'm having a hard time bringing him back again. The case is just over 2 years old, so I'd like to get another checkup on him, but to be determined. Here's a similar situation, just not as destructive. That perforative entry, we're using cone beam to determine where that is. It's near the height of crestal bone, which they usually are. You can see it's highlighted next to the DB. So all these are typically active cases with a lot of bleeding. So that fibrovascular presentation is just constant bleeding. So this image, or these images that you see here, are just, a quick shot in the dark, because about 2 seconds after this photo, the whole chamber is filled with blood. So we're not evacuating that structural defect. We're dissolving the organic tissues responsible for destruction, leaving that pericervical dentin intact. So when you want to run GenaWave on this case, sometimes I actually have to plug up the access with a little bit of cavit, build the platform in a dry environment, and then bust right through that so we can run GenaWave. But here's the result. Again, we're leaving the dentin intact, and we're just dissolving the fibrovascular tissue responsible for that destruction. Then I'm using the same technique I just described earlier, the combination of bioceramic sealer and bioceramic putty, to obturate. So it's just straight line access preparation. There's no use of burrs to excavate or unroof the defect. And that combination of BC sealer and putty flow into all areas of the resorptive defect to include obturation of the perforative entry, which was cleaned out with GenaWave. In similar example, you can see the perforative event is facial just at the CEJ on the crown margin. So here's a clinical view. High smile line. So, of course, all these cases, another little disclosure is every one of these cases, the patient knows that there's alternatives to not treating the case. A lot of times I will invite them to go visit with a periodontist in advance of treating the case, just to make sure that we don't have an unfavorable soft tissue result, and then try to get the periodontist on board. But my goal is to have an internal approach all the way, not having to go externally. Here's immediate post-op. So we've got this little lateral canal, which is kind of a, pertinent anatomy, but this is what we're really after. Again, the emphasis I want to go for here is conservation of dentin and using fluid dynamics to manipulate and clean these areas out. Building on the same theme here, you also see and again, this is kind of common where we have replacement resorption combined with invasive cervical. So they're kind of in the same dental element. It doesn't mean you can't treat it, just bone. So we're going to go right up to it. So keep in mind, this perforation is north of the orifice, okay? It's more coronally positioned, because these next images I want to show you, you can see immediately after GenoWave on the right, okay? We got obturation. Those small little tiny holes, we obturated through those little holes. So we just kind of peel back, if you want to just kind of lean back that wall of dentin, just enough to expose the area to let GenoWave get in. And then comparative axial views, again, I take them on every case, these more complex cases, just to validate that I've gotten into the areas that I wanted to. It's just easier to show the reverse contrast PA. Again, I'm using cone beam, obviously, to treatment plan these, but it's not just identification, it's also in the healing process as well. This is just similar resorption position in the palatal. But part of the takeaway message from here is that I'm not modifying my standard root canal protocol to address these complex situations. All I'm really doing is accessing, maybe peeling that wall back a little bit, and running GenoWave. I will tend to isolate these a little bit different, so I do have direct view and direct access. Let's say on this one, I might drop a 9 clamp into the palatal tissue, just so I can have a direct view of that area while I'm running GenoWave. But it's simply just making a fluid pathway and running the cycle. I know it kind of looks ugly, but again, my goal here is to preserve the dentin and to remove the offending tissue. Again, we're getting into every single nook and cranny without unnecessary removal of dentin. The special attention for a special tooth like this is one of obturation. So I think that the more challenging aspect of this whole approach to treating resorption is all really in the obturation, to generate the hydraulics to get into those areas. They also needed a bicuspid treated. But here, this is what it looks like. Here's our 2D imaging. Conservative approach. Have a new crown on this, and we'll be good to go. Um, Again, this perforative event, this was early on. This is probably one of the first ones I attempted, and this was using Son Endo's previous procedure instruments. This would have been the anterior procedure instrument, but again, this is a really good example of making sure that you're mindful of the soft tissue as well as your exposure of this enhanced irrigation, because this is a pretty big lesion, okay? But this is giving you a view inside. This is after access, before running GenoWave. And this one, I could not get to stop bleeding. So the view here on your left is calcium hydroxide. The view on the right is a second appointment, two-step, where now we have the canal obturated with the gutta percha. Everything above the gutta percha, left of that green line, is mostly BC sealer and putty, but you can kind of make out where we have an extrusion of calcium hydroxide. Some of it's already started to be resorbed. But here we are, 3 years later. Okay. Is it pretty? No. But is it functional? You bet it is. And here's a look at her soft tissue. So when treatment planning a case like this, again, I absolutely would float her by one of my trusted colleagues in perio before, in advance of doing the procedure, with the general dentist involved. So let's say if I got a soft tissue response that was unfavorable, I'm going to have my periodontal colleagues help manage that complication from the external. I'm going to stay in my lane and be the endodontist. And again, very few exception, almost all the time, where it's strictly just an internal approach. Now, this woman really did care about aesthetics in a big way, and she did not want any kind of an external approach. She was not open to the idea of surgical endodontics, nor did I think we are going to need to, but you'll get this little bit of resorption that's just near perforative, the bulk, when you look at that. So you can see it's a vital case. They all are. And here's a result. When you change the contrast, it's a little easier to see. Now you can see that entry point out on the mesial aspect. You can see where that kind of dinks its way in. Here's immediate cone beam. Small access, conservative endodontics. Patient was really happy with the result, and she just won't come back to see me for a checkup. Hey, Wendy, I've got two parts to the presentation. I can never tell how long the Q&A is going to go. But what I want to do here is also put a little plug in for my practice. There's six endodontists in my practice: Fred Simon, Michael Ribera, Kim and Hinnick, myself, Farah Sadapur, and Luke Cantamesa make advanced endo in Washington, D.C. But please check out our Instagram. Michael Ribera has a lot of time on his hands, and he gladly and happily helps put out our cases for, contributed by all the partners. Michael's the one that really runs that Instagram, so I thank him for that. But please check out. I think it's a great way to connect with colleagues and patients, and we have a lot of fun sharing cases and exchanging ideas. We're not done yet, but I kind of like to take these webinars and split them into two if we need, because I have found that I think there's more interaction and more fun in the Q&A than there is just watching me kind of crank out some more content. But creativity is about doing things differently. New experiences and learning new ideas should be full of effort. So I really, if you're not doing some of this stuff, I really want you to consider embracing this style of endo and unleash your creative side, discover what's possible. Um, with that being said, hey, Wendy, I'm going to turn it back over to you. I think we should start some of the Q&A now. We're about, I guess maybe 45 or 50 minutes deep into our time this evening.
Great. I have a lot of even questions, so I know that there's already some good questions. So I'm going to start with right in the beginning. They kind of flow through your presentation. The first question was, Scott, on those small MB2 canals that you cannot instrument and rely on sealer only obturation,
Yeah.
are you able to dry those types of canals?
Yes. What I'm using is an air only Stropco, and I take the pressure and dial it down to more of a whisper. If everyone's familiar with an ASI cart, you don't have to have an ASI cart, but a lot of us do. But I'm taking an air only, compressed air, and I just kind of squirt it at my face. I dial that down, not to full blast, but more of a whisper. And I'll put whatever I have, I'll drop a paper point in there. Of course, I'm not going all the way to length, but then I'm basically driving air, not sometimes directly into the canal, but I'm driving air over the top of it in an effort to get that thing dry.
Okay. Interesting. I came across an air embolism recently. Have you
Yeah.
ever had that happen to you?
No,
Okay.
no. And that's where I would caution you. No, this is not about driving, a burst of high pressured air into a canal. This is a little puff right across it. And truth be told, a lot of the cases, when I dry the case, I use evacuation
Yeah.
to basically suck out as much of the
Mhm.
air again as possible.
Yeah.
And then I'm only using fine paper points, which I only usually need maybe 1 to 3 of them to really dry the canal. I leave one in place. Let's say it's a mesial system of a number 19, where I know I have anatomy isthmus. When I think I've dried the case, trust me, it's not dried yet. Put 2 brand new paper points in there. Do that same exercise. Push a little bit of air at the isthmus area. And when you pull those paper points back out, you're not going to be surprised to see fluid on them. So what you're doing is you're displacing the irrigation fluid out of the isthmus, the same isthmus that you want to have obturation material in. And again, the nanoparticle technology, the flowability of BC Sealer will drop right in there, but you're not making it compete with fluid anymore. When it's dry, it'll go. So you'll see a lot more anatomy that way.
Good to know. Um, Greg had another question. In those external resorption cases, after gentle wave, how do you dry them all out?
Yeah, and that's where I try to describe maybe more of a conversation. By the way, if any of these are your questions, please feel free to unmute, come off mic. It's very unnatural, by the way, as a speaker, to stare at your own computer screen and all you see is these little black squares. So, I would love it. Folks want to be able to chat this evening. But how are we getting these dry? All right, because first of all, they want to bleed a ton on their own. And now you've poked the bear with a stick by running GenoWave. So that GenoWave is going in and really dissolving that fibrovascular component with all the clastic cells. But you still have your perforative opening. And that one central incisor I showed, that opening was huge. So I only ran at best 30 seconds of GenoWave. And a lot of these resorption cases, I might run the water test. After the water test is just about to finish, I'll stop, flush out the chamber, and look and see what I've got. And then I'll continue on with sodium hypochlorite. And I might do sodium hypochlorite at 15-second intervals for a minute. I'm not just running a whole cycle on these resorption cases where I'm just, I don't run the whole 8 minutes, extended 5 minutes of hypochlorite and just figuring it out when I'm done. No, this is a very curated application of the technology for a special anatomy. So to answer that question, how am I getting it dry? All right. So once you run this and you finish knowing, of course you're going to have bleeding. So I mentioned it. I call it a Mac tip. That's what I call it. It's basically a small lure lock that's very open-ended. So instead of having a constricted opening, it's a very open opening. It's very open at the end. So when I literally push it right to the pulpal floor, and I am shoving with a lot of force. So basically, it's almost like a fire hose effect of hypertonic saline, 3% saline that's chilled. And 2 or 3 of those, and it's quiet.
So you have
I
them in a
do not
syringe on
like,
the tray?
yep, just a
Yeah.
10 cc syringe. I do not like to use for any general, let's just even back it up. And let's say that you're an individual that still likes a bigger prep size. Let's say you're putting 20 tip sizes, 25 tip sizes. If you're still using 30 tip sizes or '06 taper instruments, I would really encourage you to rethink some of that. And you don't have to drop down. Most of what I do is a 17 tip size '04 taper. If you're not comfortable going that small, but at least start to get closer to smaller, because I would imagine you're going to have a lot of bleeding issues with GeneWave if you're putting a 30 tip size or an '06 taper, anything within a millimeter of that portal of exit and running a full cycle of GeneWave, you're going to be dealing with a lot of bleeding. So I'm not a very big proponent of using hemostatic agents or there's all these little tricks to get the bleeding to stop. I just freezing cold saline, I think is the easiest way to do it. And another, while we're on the subject, if I do have a canal that's really bleeding a lot, this is not resorption. This is just any GeneWave case. It's bleeding, it won't stop. I just, up against the bleeding, I push, I go upstream. It's bleeding. I put a minimal waste tip. I just squirt some bioceramic sealer up against the blood, drop a cone, and just let it sit. So I sear off that cone against the wall, clean out the chamber, obturate the other canals, and by the time I'm done obturating the other canals, the sealer that I provided into the canal and kind of pushed down to the portal of exit was just enough to cork it. It's dry. I irrigate all the sealer out, dry the canal, and continue on with my work.
Okay.
Yeah.
Let me ask you a question about if you have, let's say, a larger canal, and you are going to use a 3006, 2506. Can you help me understand why that might get more bleeding than if you just chose a really small file, if the canal is already large?
Sure. I think it's just too much mechanism of action up against that tissue interface. So you're really, most of my cases, you'll see patency demonstrated on obturation. So you'll see a little sealer puff, little sealer button. The only thing I'm going patent on any of my cases is an 8 file. And that's just to confirm working length with EAL. That's it. The remainder of it's just usually a path file, one or two path files that are either 13 or 16 tip size '02 taper, but I'm working a millimeter back from solid tone EAL. And then what I like in my hands, there's so many options and there's so many choices for minimal size tip instrumentation now. I still tend to like SS White in their DC taper system. So I use a 17 tip size '04 taper. But when you put that instrument up against a standard 15 headstrom, it is similarly sized. So it looks just about the same as a 15 headstrom. And that instrument at D16 is no bigger than 0.49 millimeters. That's that's the size of that's the diameter of that stock. So once you get past orifice level, you're not putting anything that's greater than a half a millimeter. So you get to conserve a lot of pericervical dentin. Um, but sorry, Wendy, if I got off track, I don't know if I answered
Yeah.
the question properly, which was the tip sizes. Okay.
Yeah. Oh, good.
So now when you go down, I think, in my opinion, with enhanced irrigation, O6 taper only has historical value. It really does. You don't need it. You have to trust the technology. What are we doing? We're just dissolving that tissue. I mean, go check out David Yamario's lecture. I mean, he's got some very comparative histology using all modalities of enhanced irrigation, and Genowave crushed them. So I think the smaller you go, the better off you are. So if you're using an O6 taper, you're still kind of mincing up and crushing, mushing, and mashing that collagen in the canal, and you are shoving it into the exact areas that you want to be open. You want some sealer to go into lateral anatomy, isthmus anatomy, and you're making that technology work a lot harder to clean those areas. Where if you go smaller, you're gonna make life a lot easier for you.
Great.
It's also pretty difficult to put an O6 shape in a lot of these teeth. It's a lot of work.
It's a
You know what
lot
the law of least effort, Wendy?
of,
There's an
yes.
easier way to do it. Let's go that way. Okay.
All right, I'm going to stop talking because I really want people to engage. There's some really good questions. If you want to come off mute and ask Scott directly, great. Otherwise, I will ask, but I'm going to pause here. All right, I'm going to ask them. So, Scott, how much putty are you using? And are you using high flow and regular BC sealer? So, let's start with what BC sealer do you
Yep.
use? And how much putty?
Absolutely. By name, Brasseler's Endosequence BC Sealer.
High or
Um,
regular?
High flow.
High flow,
I
yeah.
just we've chose high flow. I like it. I use both. They now have a new product called Ion.
Yeah,
Um, and they're just my opinions. The whole lecture is just my opinions. It doesn't make them right. It's just my opinion. It's just there's so much research and histology based off of the history with Brasseler's endosequence. So I think there's a lot of other brands that have come on the market. By name, they're bioceramics. But I would encourage you, if you're using those products, to just examine what is the calcium silicate content, what other things are in there. Is there aluminum in there? There's the formulations are kind of all over the place. So it's like buying organic food now. It's hard to really tell what are you, just because they put the label organic doesn't really make it organic. So just because the label reads bioceramics, all those wonderful properties that are well studied with Brasseler are not transferable by name to anything else. So I feel
sure.
very strongly about using BC Sealer by Brasseler. Um, I think there was another question in there about maybe
Then how much
high flow.
putty are you using? If you could demonstrate
Oh,
that.
for those cases,
Yeah,
I'm really looking for, it's kind of selective, like that one, the whole pulpal floor was blown out.
yeah.
So again, it's a prophylactic root canal. You're just straight line access. You're doing your standard root canal is really what you're doing. Go ahead, perform the endodontics, run Genowave, and when you're done, you obturate. So you have that pulpal floor. I'm just making sure I have an adequate amount of sealer. And then the putty, what I'm really trying to do is I want to drive that putty into all those irregularities. So I guess it's not really a volume, it's so case specific, but I mean, it's okay to have access. I would imagine, what would you like if you didn't have enough? If you didn't have enough, I'm using, I use gutta percha. Michael Ribera, my partner, when he approaches these cases, he uses Teflon. he packs up against the putty with a wad of Teflon. It's same effect. All you really want to do is generate hydraulics. So even with those minimal waste tips, look at those little ticks on the side. You see they have these little tiny lines on the side of the sealer,
Yeah.
and it costs around, almost $8, $9 when you start pushing that tube just to get sealer to come out the tip of a minimal waste. Okay. And those are the aftermarket ones. If you use the ones the manufacturers give you, you're spending $15, $18, $20 just to get the sealer to come out the end of it. So it's expensive, but I think it's well worth it. It's well studied. Um, and I think that is absolutely part of the success that we're having with enhanced irrigation GeneWave, and minimal tip sizes. If we didn't have these sealers, I don't think we'd be as successful with that technique.
Sure. Speaking of materials, do you use the heavy or the light gutta percha? They're doing a backfill.
Um, I just use calamus. So it's not, you think I would know. I use a calamus, and we buy it from Dentsply. So if there's different options, I apologize if I don't know, if I'm not aware if they are, if there are options, but that's what I use for backfill.
Sure, there are two options, but I'm glad that your
I will
assistant knows. But
I will find out when I go into
okay.
the office tomorrow. See.
Uh, all right. Are you concerned about hypo accidents and upper molars with proximity using gentle wave?
No. And again, after using this for 8 years, um, the science just behind clean flow, it generates a lot less. Actually, it's more negative pressure. It's a safer instrument. I'm not saying it's idiot proof, all right, but I think if you're honest with yourself and how you're shaping, um, I have no problem. When I used a molar PI, I would really modify. This is years ago. I would modify my shapes when I had what I call critical anatomy. Now I have absolutely no fear or concern that I'm putting my patient at danger. What I'm saying, I would do it to myself. I would do the same thing to myself. I'm not going experimental or a cowboy, but
Sure.
I don't really modify the shapes at all. Even let's say you have, um, a buccal and a buccal root of a maxillary bicuspid that's near perforative or has pathology, so there's no cortical plate and it's just out there kind of in soft tissue. You see, and you should still use your own judgment, listen to that voice in the back of your head. But I mean, knock on wood, it's been 8 years. I have personally not had one. So I just think clean flow is much more predictable
Yeah,
when it comes to generating pressures. And I think that you can still just follow your normal protocol for shaping, um, without without any issues.
great. I like this question. I had it too. How are you ensuring no leakage of gentle wave irrigation out of the external cervical resorption communication?
Yep.
So that's central you did.
Yeah. So I will isolate, let's say at central, I will take that 9 clamp and I will drop it right into the attached gingiva. So when I'm isolating that case, the wings of that 9 clamp are right at the incisive edge. A lot of these are, by their namesake, cervical resorption, so you don't have to go that far to achieve that. And again, if anything, if there's a breach, GeneWave is going to pull through that. Again, I've got thousands of cases and to base that off of. So what I mean is, you're basically spraying a light mist inside that tooth. It's high volume, but you're spraying that light mist, And as that mist collects, it turns into foaming bubbles. And you have all that exchange. But if there's an opening, it wants to pull air through that as opposed to sending fluid out.
So when you said you went below, right at the cervical resorption with the 9 clamp,
Yep.
what do you do after that?
So I'm taking the rubber dam. So let's say I'm going to isolate for that central incisor.
Yep.
I'm going to, I'm going to, I won't just do one teeth. It'll be 3 teeth so I can get a little bit of pull on it. I'm going to pull that dental dam down deep onto the alveolus. So I'm going to have full view of the crown. I'm going to have full view of the free gingival margin. I'm going to have full view of the attached gingiva that's overlying the resorption. Deeper than that, that's where I'm dropping that 9 clamp into soft tissue. So I have full view of soft tissue for all those cases.
And
And I can pull up, go ahead.
you said 3 tooth isolation with the 9 clamp. That confused me a little bit.
Oh no, the rubber dam. So
Okay.
the rubber dam itself, I will stretch over 3 teeth to give
Okay.
myself a little bit more pull. If you just do one tooth,
Yeah.
that rubber dam, the exposure, the dentin's really skinny.
Yeah.
If you go over 3 teeth, when you pull it down, you'll have a greater view of the gingiva. You'll have
Okay.
more gingiva exposed. Short version, I want to be able to see that tissue while I'm running GenoWave.
To make sure that there's not leakage or what do
Yeah,
you mean? Yeah.
leakage or it's not turning red, there for every reason.
Sure.
Again, I pointed it out during it. I want to really say this again. It is absolutely an off-label use. But I think a lot of us that are very comfortable with technology, their manual also says you can't treat third molars. I treat third molars with GenoWave. So I think they have a lot of FDA regulation, I think for good reason. But again, we're the doctors, it's the technology. We're just going to choose how we're going to apply it.
Sure. Another follow-up question, but number 9 had a really large lesion on the radiograph. Do you have any concern with using gentle wave there in a hypo accident, the size of the apical lesion? Is that
Yep. That's another good example. No. So you're talking about the one with the resorption where it had the little lateral canal up the buccal. I think that's it. But no, I think that is a perfect example where it was a very open case. And that's the type of case where I will put in a 1704. So when the canal is large, that 1704 is really just kind of floating. You're not really cutting dentin. You're creating a fluid pathway right down to approximating the portal of exit. When I'm running GenoWave, it'll dissolve and pull everything out.
great?
So no, so to answer the question is no, I'm not concerned about that. In fact, I'm not getting that lateral canal unless I use GenoWave.
Sure. What cone beam do you use? What brand?
We use CareStream in our practice.
Okay.
Between the 3 offices, just based on when we purchased them and what was available, we're not all 3 offices. We have 3 locations, and we're not in sync. We don't buy 3 cone beams at the same time. So there's different versions. But it's what I use downtown every day is a limited field of view. So it's a 5x5 CareStream.
Some
75
people
by
were
5.
asking if you're using the cone beam for post-op radiographs
Yep.
and your pre-op.
Yep.
Yep. So Steve Buchanan was very happy for that. He appreciated the use of how you're using cone beam. But talk to me a little bit about the post-op cone beam. When did that start? And is that just mandatory on all cases?
No, 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 no. So I'm always going to take 2D imaging, and these are just what I would call select cases where I need to validate. Like the case I said I literally just did it yesterday. The cases where I need to validate that I've gotten into that little isthmus, you could see it a little bit on that 2D. And also it's just, let's go that theme of curiosity. I want to see where it's coming from too. Okay. But I would say all my like the endoperio cases, I take an immediate post-op with cone beam. The resorption cases, 100%. Because let's say I've done it before where I've done the same protocol and I didn't get obturation to go in all those areas. So what I'm assuming is I still have clastic tissue, plastic cells in fibrovascular tissue in that area communicating up to an area where the perforative event is. That's when I'm going to go back to my periodontist and say, hey, folks, go ahead, lay some tissue back and perform that external repair.
Sure.
But it's not my so just to be really clear, my go-to is post-op 2D imaging, followed by, I usually have somebody by either at 3 months or 6 months for post-treatment cone beam. I do all my recalls with 3D imaging. 100%.
Okay. Okay, that's good to know. So Steve's off mute, which is awesome. We'd love to hear from you. He also has a trick of drying if you want to speak, Steve.
Yeah.
I just wanted to share an experience I had with my good friend Roger Warren in Salt Lake City. He always calls me before he buys expensive endo gear, and he asked me, about the cone beam CT imaging and gentle wave, and he used both of those. I talked to him a month after he got his gentle wave, and he said, I'm not seeing that big of a difference. Of course I see lateral canals, but I saw lateral canals before. And I asked him, do you do post-op CT imaging? He goes, no. I said, call me in a month. Do that and call me in a month. He goes, oh my God. The hidden view is always where all the complexity is. And then he got all psyched about it. And he's into a constant, he takes post-op CBCTs on everybody. So bravo,
Awesome.
Scott.
Yeah.
Thank you.
I'd say it's a decent, and anytime that I have anatomy I know I'm going after, like I to kind of describe targeted, I absolutely take it because I want to know that we've got the job accomplished.
This is another good question. At what point, if the patient is asymptomatic, when do you decide to treat the resorptive defect?
And there is a conundrum there. I tell you what, in all the ones I've chosen to treat, so again, they're coming out with different classifications, different descriptions. Let's just go with what everyone's probably very familiar with, which is Heather Say's classification of 1, 2, 3, 4. I'll go into 3, but I won't go into 4. Okay. When I'm down and past the coronal third and it's really wiped out, it's just there's so much destruction. It's really a risk. It's a risk benefit ratio, and what I would do in my own mouth.
Yeah.
Second is when we choose to treat. Now I've had patients also decline because I do talk about all the options. Okay, it's not like I'm limiting them to only that option. Of course, I have folks say, you know what, I'm going to let it ride. I go, perfect. So it's anecdotal, but I'm like, come back and see me in 12 or 18 months, and we can recone beam and we can compare the areas of low density and see, hey, is this advanced? Has it not advanced?
Yeah.
But on the heels of that, I have yet to go into a case where it's fibroosseous. That means just it's ashen, all the destruction's done, that soft tissue is just retracted, and it's just kind of just barren and, dormant.
Right.
I haven't seen it.
I don't see that either. I always struggle with this question. Why did this happen? How do you answer that? Why do I have resorption?
You know what? We know a little bit more about the mechanism, but we don't know where the on switch is.
Yeah.
So
I blame it on ortho. My dad's an orthodontist, so I can do that. But
yeah.
All right. So Scott, you mentioned off-label use. Are you running gentle wave full 8 minutes for most cases and skipping through hypo and EDTA only for resorption cases?
In fact, no, so to answer all parts of that question, every single case that I run, because I don't have the advanced protocols inserted yet. I don't have the only extra control I have are adding 1 minute. I do extended hypo for every case. And I also most times move it to 5%.
So you have the upgraded G4 model?
Yes. So
Okay.
I'm using a G4 where I'm pushing 5% hyperchlorate instead of 3%. I always go the extended because in this current in the current status, you can't get into a case and add time. You can always subtract it. But in my go-to standard case, when I go to the office tomorrow, the cases I treat, I'm going to treat with 5 minutes of hyperchlorate and the full EDTA cycle. All right, that's our standard case.
Yep.
Now, let's take resorption. Let's take the next resorption case I treat. I am absolutely going to expose that to sodium hypochlorite. I'm not likely to use the 5%. I'll keep it at 3%. But every one of those resorption cases you saw had an application of sodium hypochlorite. Did all of them receive 5 minutes? No way. Did most of them receive between maybe 2 and 3 minutes? I'm also watching what comes off that machine. And, on your standard case, your go-to, GenoWave case, it's a little bubbly. Maybe it kind of looks like champagne a little bit. It's starting to look a little foamy because you're interacting with the tissue interface. You're mixing hypo with heme. It's foaming up. But then if it ever starts to look like rosé, that's a problem. Okay. So there's way too much action happening at whatever portal of exit, whether it's resorption or just a kind of a big open palatal apex. It's too much action. So that's where I stop. But it's variable. So I would just say I do stop. And so let's go back to those resorption cases. It's off label. I'll run almost the entire water cycle. I'll stop and take a peek. I'll just flush out the chamber. I'll look, see what I have. Okay. Then when I start on hypo, I might just run 15 seconds of the hypo, stop, take another peek again. Or I'll run another. So I do it in smaller increments. I'm making sure that everyone knows, no, I'm just not putting it on, walking out of the room, letting my assistant hold it, and ripping off 5 minutes of hyperchlorite. In fact, I know I still hold the PI myself as the doctor 90% of the time. Okay. Part of it's just, we have, it's more internal. We have 6 doctors. We have different staff. Each staff works with different doctors. It's just, if I had my own solo practice, I could train everyone to hold GenoWave now with clean flow. I'd be comfortable with that. Before clean flow, I would say that's probably not a good idea. But with clean flow, it doesn't leak and it's a lot more safe. Or I feel more comfortable about the safety.
Sure.
Yeah.
Someone's asked about lasers and gentle wave and the differences. We just had a webinar last month with Mustafa. It is incredible, and he goes over all those questions and answers. He's not biased. So we just put it up on our GenoWave YouTube channel, GenoWave Doctor. It's on our VIP portal. Highly recommend watching that to learn the differences and case selection. Let's see, anything else here that we might have missed?
Well, I could start picking on some people here. I mean, I haven't heard from Heather. I haven't heard from Karen Potter.
Karen Potter, I know she dries just like you. I was thinking about that.
Thanks, Steve, again for everything. I kind of gave you a shout out in the beginning, but I really do. Steve's one of my mentors from USC, and he continues to inspire me this day. So I really appreciated him attending. Steve, that was really appreciated that.
Thank you. Could I just add one comment?
Sure.
And your technique is really great. I love the idea of running short little cycles of hypochlorite and checking, running it and checking. But my experience with GenoWave is if my access was correct and I don't have any undercuts that's going to impede the outflow of the fluids. I've done open apex cases. I've done them under the sinus The only problem under sinuses was if I get paint into the sinus, I get air coming in from the sinus
Yes.
space, and that's an issue. But I've never had an issue with any indication of extruded hypochlorite beyond the terminus, regardless of the apical diameter. What does happen is the larger the diameter, the more likely that the EDTA is going to it's going to reduce the clotting up there because it's a anti-clotting. You know, they put EDTA in your blood sample bottle. So I don't worry about that. And your freezing cold hypertonic saline is the bee's knees. It works every time. That's perfect. Yeah, good job.
Where
Yeah.
do you order that from?
My
It can be a little
assistant,
bit difficult.
my assistant, we buy 1 liter, we buy 1 liter bags.
Okay.
I think they use a medical supply company, but we buy 1 liter sterile bags and they just draw it from that each morning
Right.
when we want to use it. That more for the cases, they draw it up into 10 cc syringes the morning of.
Okay, great. So this person has 3 different questions. If we're pushing sealers in areas of external communication, are there any chances of how can the external resorption of sealers, what are the implications and how can they be managed if sealers are getting out of
Well, yep.
the
So,
tube?
yep, any basically extruded sealer. Let's
Yep.
kind of qualify it as that. Just extruded sealer. I have with the choice of sealer that I've made my go-to, I have 0 concerns. The biocompatibility and the bioactiveness of that material, I have 0 worries. On the rarest occasion, yeah, there's a difference between a sealer puff, a sealer button, and a sealer blob. Okay. We want to avoid the blob. But if you're practicing it, there's a lot of people on this call. I mean, everyone's had some of that experience, but it just depends on what sealer you're choosing. When you go historically, just before BC sealers, specifically endosequence, now, every one of those sealers was known to be cytotoxic. So yeah, there's gonna be a big problem. Critical anatomy that I'm worried about, of course, is our vascular structures, neurovascular bundles. Of course, I don't think it's safe to put a bioceramic sealer up against the IAN. Bad idea. But anything else? No. You saw, I mean, just a couple of the cases I chose to include tonight certainly had probably sealer extrusion that some people would kind of turn their head out a little bit, but I got to generate hydraulics to complete the case. So I do have my goal was to have the entire canal filled with sealer. I introduce a gutta percha point, and that gutta percha is only there as a carrier to displace and move that sealer. Sealer by its namesake, sealer is the sealer. Gutta percha doesn't seal at all. Okay. So I'm perfectly comfortable with a full sealer obturation, and it sets. Another person I highlighted, the Endo on Demand at AE.org. Also, check out Jenny He. Her last name's He. Check out Jenny He has some extraordinary, really wonderful and thorough presentations on bioceramics. 100%. Go to AE.org and check that out. But I think you get, some more, a very layered evidence-based explanation from Jenny. But bottom line is they're biocompatible. So you said there's 3 parts, but basically I'm not concerned if I have external sealer.
The other part was what concentration of hypochlorite in EDTA do you use? That's
It's basically, yeah, I can only really control the hyperchlorite, and most of the time I'm going for the 5%, and the EDTA is kind of just set at 8.
Yeah. And then can you share any knowledge you might have on irrigant effectiveness when we can compare acoustic energy versus heating the irrigant.
I'm not really,
Right.
you can get Kevin on the line and he can answer that. Of course, I did get a chemistry degree from the University of Pittsburgh.
Right.
But it's just, I would imagine heating it, you would increase the efficacy. There's got to be some reason with FDA approval that they chose not to have the irrigation fluid heated with GenWave because it's not. That must have been some kind of choice with either safety, efficacy, or FDA approval. I don't know. I wasn't there. I didn't do it. Um,
Yeah,
but
that's a good question. That's the first question I've had too. So thank you for asking that.
yeah.
All right, guys. So we have a few more minutes left. Please come off mute or you can keep your camera off and ask anything else that you want.
Let's see here.
Dr. Hetz, I have a question. Good to see you. Ricardo Wasmer here.
Hey, Ricardo, how are you?
Good, good. Great lecture. I just had a question about your standard obturation technique. You mentioned you fill the canal with sealer, you place the gutta percha cone, but do you also add that thermoplasticized gutta percha to generate more hydraulics to fill those extra ramifications?
Yes. Yeah. So let me flip back over here. That's exactly it. So especially with smaller canals, you can kind of imagine you have that mouth of the orifice, and when you drop your cone in, you're going to displace some of that sealer, so you have a small puddle of sealer around that opening. Your first choice, which everyone's kind of taught, is let's downpack that. Let's take a system B, Stephen, and downpack that. But when you do, you're losing sealer up the side. So what I choose to do is, instead of the immediate down pack with heat, I squirt thermoplasticized gutta percha around the orifice. Think of it as almost like kind of taking soft serve ice cream and kind of just squirting it around there, then taking a larger plugger and pushing against it. What I'm doing with that additional thermoplasticized gutta percha at the orifice level is keeping the sealer in the canal. And when I push, it creates an envelope of hydraulics that will then push the sealer down into lateral anatomy, the full canal, the portal of the exit, instead of it popping up the side. It's kind of messy. You have now a combination of sealer and gutta percha all over the pulpal floor. Then grab your heat, take a bite of that, and you just have the little orifice left. I give it a little tap on that, and it's done. But it's just another way to generate hydraulics. It's another way to push the sealer into those small areas that we want it to be into.
Right
Right.
on. Thanks, Dr. Hetz.
Yes,
I learned from
and also,
Dr.
not a plug
Dr.
for myself, but I did have, again, I go back to the endo on demand, and I think it was 2 years ago, 2 or 3 years ago, I have recorded a lecture that's strictly on obturation. So I talk an hour and a half just about obturation. You should be able to find that using my name and at the endo on demand.
Awesome. And you're not coating your cone with sealer, correct?
No, not at all. In fact, I just fill the entire canal. That's it. Another little helpful trick that I use is, the sealer is expensive. All right. It's probably one of the most expensive things we got going on that tray. Gutta percha is not. Gutta percha is dirt cheap. Okay. So think of your gutta percha cone just as almost like a paintbrush. I kind of drop that cone in there, see what it feels like. When I'm drying the case, I have a good idea what gutta percha I'm going to use based on the shape. But drop the gutta percha cone in, just send it home. Pull it out and look at it. You'll see either the tips kind of crunched up a little bit. It's coated with sealer. It's not coated with sealer. It also takes that sealer. You can't guarantee that application of sealer is going to go down and fill the whole canal. Let's say you only got 3/4 full. That first pass with a gutta percha cone kind of drops that down and wets the wall. You can add a little bit more sealer and then drop a second cone. Take the first one, sacrifice it, just throw it to the side. All right. I think what, a whole box of gutta percha points is $9. So again, I think it's going to give you more predictable results. I don't take any down pack images. I don't take any wire images in most cases. Occasionally I will, but I take a pre-op vertical bite wing. I typically have some kind of a PA from the referral, and I take a cone beam. I always take a vertical bite wing for restorative and perio, and then to look at the hard tissues below and the anatomy diagnosis, I did the cone beam. The very next radiograph I'm taking, the rubber dam's off, and I'm taking final images.
So that's interesting. I still like my master cone radiograph. How many times do you have to put the rubber dam back on? Have you just found like, is that something new the schools are teaching, do you think?
No,
A little older
I don't
than
think
you, like,
I don't ask Michael. He thinks I'm nuts doing that, but it's we live in a 3D world,
yeah,
and the worst radiograph. This is my opinion, by the way. The worst
sure.
radiograph we take, if the rubber dam's on, you're asking the patient to hold it. They're choking. It's at a bad angle, and why? And this is my opinion. Why am I going to modify my whole treatment based on a crappy 2D image where I'm confident about the 3D pre-op, and between tactile sense, EAL, drying with paper points, et cetera, et cetera, et cetera. If I have any doubt, of course, I'll take an image. But almost all the time, all that information stacks up in a linear way, giving you a lot more confidence. And I just run the case through. Maybe, Wendy, 1 in 500, maybe 400 cases, I take the rubber dam off and the gutta percha point bent over.
Right,
There was a gutta percha no sealer.
right.
I just put the dental dam back on and repack that one canal.
Sure.
It's from a time perspective, it's a no-brainer in my book.
Great.
I'm probably the minority, but it's just the way I work.
I'm finding it's interesting the more I asked, people aren't taking that. Kelly just asked if anything did go wrong, legally, do we need that shot at all? That radiograph of a file or anything during treatment?
The only standard of care in endodontics is a rubber dam and a pre-op image. Those are your
Yeah.
standards of care in endodontics.
I think Kelly, when I hear that question, I always thought of if a patient would swallow a file, you
Oh,
do need to show that a rubber dam clamp was on the tooth. So that's the only legal thing I've seen and been worried about. Okay, we've got one more time for a question. So I'm going to open up the floor and see who wants to ask that. Please, someone do, or we will call.
well, Wendy was asking me about a 29029 Everesting challenge before we started.
Yes.
Maybe I can ask Wendy a question. But no, I think, but it looks like we're going to wrap up here, though. Everyone's time's valuable. I normally am absolutely dead asleep by this time at night. It's 9:30. I wake up at 4:30 every day. I did take a walk after dinner and drank a full cup of coffee so I could be awake for my own webinar. But I appreciate everyone on the East Coast for taking time away from their family, and also the folks on the West Coast that probably just maybe stayed at their office after work. But your time's valuable, and I appreciate you spending it with myself and the whole gang this evening to learn a bit more about our specialty and what we do in our office every day to help our patients.
Thank you so much, Scott. We are going to wrap up with 2 more slides here.
Okay.
Just to review.
Oh.
Okay. You can put it in the chat too while I do this, and you can ask Scott anything in the chat if you've got one more question here. Our next webinar is always the 3rd Wednesday of the month. So this one is a special one. It's August 20th. It's with Xenia, who is Dr. Kurt Corey's dental assistant. And it is going to be a live webinar where she's going to talk about office workflow and console maintenance for the dental assistant. We want you to share this with your own dental assistants, and if they can share with their peers, they will get CE for this, the dental assistant. We will also put it up on our VIP portal and Gentle Wave Doctor YouTube. So we felt that this was a big need that people were coming us to. So please include your dental assistants next month, August 20th. Same time, and we will make sure we share that on the internet also. Our next upcoming hands-on course is going to be in September. We're giving you the summer off to enjoy your family. September 12th is Sonia Chopra. It's in Charlotte. Again, it's a hands-on course. She has her dental assistants there too. So make sure you sign up for that. That one does get very full. You can find that on our website through me, QR code, and anywhere else that you need, please reach out to me for that. All right. Thank you, everybody. 6:31. The best lecture is one that ends on time, I've always found, so we did it. All right. Enjoy your night. Everyone have a great night.
Appreciate you, Wendy.
Okay.
Thanks for your help.
See you later.
Bye-bye.
Bye-bye.